Hey everyone, welcome back to our channel. Today, we're diving into a crucial topic, managing iatrogenic endodontic events. In our line of work, unexpected complications can occur during endodontic procedures. So, in this video, we'll explore how to handle issues like instrument separation, lesion, and more. By understanding these challenges and mastering effective management techniques, we can ensure smooth sailing through any procedure. Let's jump right in and enhance our skills together. Don't forget to like, subscribe, and hit the notification bell for more valuable content. Let's get started. Sodium hypochlorite, NaOCl, extrusion. Rapid and startling progression. NaOCl extrusion into periradicular tissues leads to rapid and alarming outcomes, leaving both the patient and practitioner wary. Properties and uses. NaOCl is effect-disrupting biofilm, dissolving necrotic tissues, and removing organic components of the smear layer. Despite its efficacy, it is extremely cytotoxic, even at low concentrations, causing severe tissue damage. Complications and causes. Complications often arise due to inaccurate working length, iatrogenic widening of the radicular foramen, lateral root perforation, or wedging of the irrigation needle. Facial distension and swelling. Similar to cervicofacial emphysema, NaOCl extrusion causes facial distension and tissue destruction, aggravated by effervescing agents like hydrogen peroxide. Clinical presentation: 3 days following the extrusion of NaOCl during treatment of the maxillary. Right canine. The patient had difficulty opening her right eye, and the swelling had extended to the submandibular/sublingual regions on the affected side. She also experienced limited mouth opening. There was altered sensation infraorbitally and in the region of the upper right lip, but no reported paresthesia of the alveolar or facial nerves. Immediate patient reaction. Patients experience severe pain, marked edema, bruising, and spontaneous hemorrhaging. Maxillary posterior teeth may lead to periorbital pain, chlorine taste, or throat irritation. Complications and management. Complications include paresthesia, both transient and permanent, and motor nerve dysfunction. Immediate cessation of treatment is crucial, followed by measures to diminish the chemical's effects. Treatment protocols. Pain control with local anesthetics and analgesics, cold compresses, and warm oral rinses. Immediate irrigation with normal saline to encourage bleeding and dilute the irritant. Antibiotics and corticosteroids may be prescribed based on severity. Close monitoring for any signs of airway compromise or worsening swelling. Prevention. Attention to detail and understanding fluid dynamics are crucial. Key preventive measures include establishing accurate working length, careful irrigation techniques, and avoiding wedging of the needle tip. Takeaway. Prevention is paramount in avoiding NaOCl extrusion complications, requiring meticulous attention to detail and adherence to established protocols. 1 month post-extrusion, the ecchymosis had resolved, with a return of sensation and full function. Therapy was completed without incident. Preventive measures for sodium hypochlorite, NaOCl, extrusion. Establish accurate working length, avoid overinstrumentation. If using positive pressure irrigation, use a small side-vented needle placed at least 2 mm from the working length. Express fluid slowly and ensure it vents through the access cavity. Assess canal integrity for perforation signs or large fluid egress portals. Avoid wedging the needle tip or inserting it beyond the working length. Confirm solution identity before injection or irrigation. Introduction of nickel titanium, NeD, rotary instruments revolutionized endodontics. Perceived increase in separated instrument occurrences with NeD rotary files. Separation may occur more frequently with NeD rotary instruments compared to hand instruments. Separated instruments can usually be discerned on radiographs by distinct radiopacity within the canal. If canal is subsequently obturated with radiopaque materials, separated instrument may not be visible on radiograph. Separated instrument may become apparent upon removal of filling materials or visualized under dental operating microscope, DOM. Common causes of instrument separation include improper use, inadequate access, overuse of the instrument, excessive radicular pressure during instrumentation, continuous use of a large instrument in a curved canal. Other contributing factors include operator experience, rotational speed, canal curvature, instrument design, torque setting, manufacturing process, needy alloys, type of rotational motion, type of tooth, and absence of a glide path. Incidence of separated needy files ranges from 0.4% to 23%. Molars, especially mandibulars, have a higher incidence of instrument fracture due to accessibility to the canal, diameter of the root canal, and root canal curvature. Instruments fracture due to cyclic fatigue, torsional fatigue, or a combination of both. Cyclic fatigue is caused by repetitive compressive and tensile stresses, while torsional failure is when the tip of the instrument binds, but the shank continues to rotate. Smaller instruments with smaller tapers are more resistant to cyclic fatigue, while larger instruments with greater tapers are more resistant to torsional fatigue. Reciprocal motions are reported to extend the lifespan of an instrument and increase cyclic fatigue resistance. Instruments should be discarded after use in severely curved canals to prevent instrument fracture. Management of separated instruments includes non-surgical orthograde or surgical approaches. Mechanical removal involves dedicated tools such as extractors, wire loops, post-removal systems, ultrasonics, and laser irradiation. Chemical removal uses solvents for instrument corrosion or electrochemical process for dissolution. Surgical approaches include radicular surgery, intentional replantation, root amputation, or hemisection, but are considered relatively invasive. Non-surgical removal methods include hemostats, forceps, needle holders, or pliers to grasp and remove instruments above the root canal orifice. Spoon excavators, retrievers, or specialized devices like endo-cowboy for coronally directed pressure removal. Braiding technique using multiple files to grasp and extract a bypassed instrument. Macering kit for exposed coronal portion removal within the straight part of the canal. Endo safety system or endo extractor for smaller diameter trifine burrs and unique extractor mechanisms. Canal finder system or endopulse system for vertical movement and mechanical engagement with separated instruments, assisting in loosening or retrieval. These systems are technique sensitive and require caution to avoid root perforation, especially in curved canals. Ultrasonic instruments are effective for removing separated instruments, but needy files tend to fracture repeatedly under continuous ultrasonic application. Stainless steel instruments are more resistant to ultrasonics and are easier to remove than needy instruments. Small ultrasonic instruments allow continuous and improved vision of the field. Ultrasonics, especially under the dental operating microscope, DOM, enhance both preparation and removal procedures, providing safety and accuracy. Ultrasonic tip is placed on the staging platform between the separated file and the canal wall, vibrating around it to apply an unscrewing force. Drawbacks of ultrasonic use include accidental extrusion of the file into bone, separation of the file into small fragments, and pushing smaller fragments into more radicular levels, increasing difficulty in removal and risk of perforation. Smaller file fragments are easier and faster to remove than longer ones, while long instruments separate a shaft can be grasped with forceps or pliers if reachable. Successful removal of separated instruments depends on various procedural variables. Success rate for removing separated files varies from 33% to 95%, with ultrasonic techniques taking 3 to over 60 minutes. Variations in success rates are due to factors such as location of fractured instruments, diameter of the root canal, degree and radius of canal curvature, operator experience and fatigue, and length of the separated instrument. Visualization and accessibility to the separated instrument are crucial for successful retrieval. Success rate is high for separated files located before the canal curvature, moderate at the curvature, and low beyond the curvature. Success rate is higher with canal curvature and longer radius of curvature. Combination of ultrasonic techniques and microscopes typically improves success rates in file removal. Removal attempts of separated instruments from root canals should not exceed 45 to 60 minutes to maintain high success rates. Prolonged treatment time may lead to reduced success rates due to operator fatigue or over-enlargement of the canal, increasing the risk of tooth integrity compromise and perforation. Visualizing the rated instrument under the dental operating microscope, DOM, may indicate a less challenging scenario. It's crucial to avoid sacrificing excessive dentin or causing canal perforation during instrument retrieval attempts. Accurate diagnosis and treatment planning, including the use of cone beam computed tomography, CBCT, are to prevent procedural mishaps. Separated instrument removal attempts should be made after completion of preparation based on the treatment plan, which may include surgical interventions or retention of the separated instrument as part of the obturation. Conditions for separated instrument removal attempts. Root canal preparations can be conducted in either a dry or wet environment. Dry conditions provide better visibility under the dental operating microscope, DOM, and prevent additional procedural accidents. Root canal preparations for instrument removal should be conducted in a dry condition. Heat generation by ultrasonics is inevitable and can damage periodontal tissues if the temperature rises above 10 degrees Celsius on the external root surface. Separated instruments are susceptible to secondary fracture when in contact with ultrasonic tips. Pulsing and in/out motion should be used during sonic activation to prevent secondary fracture and temperature rise. Ultrasonic tip should be activated at the lowest possible power setting. Removal attempts can be made in a wet condition using a fluid to take advantage of cavitation and acoustic stream, facilitating instrument removal. Ethylenediamine tetrasacchide, EDTA, solution or oil with low surface tension is recommended as the fluid, as EDTA removes hard tissue debris and oil enhances lubrication to aid in instrument removal. Root canal preparation for visible instrument retrieval involves several steps and considerations. Goal. The goal is to make the separated instrument dance by enlarging the canal and loosening it with ultrasonics based on the diagnosis and treatment plan. Instrument characteristics. Most separated instruments are needy, with a mean of 2.5 to 3.5 mm and a coronal diameter of about 0.30 to 0.58 mm. Enlargement techniques. If the coronal diameter of the separated instrument is smaller than 0.45 mm, use a number 3 modified Gates Gleiden burr followed by a microturfine burr. Unscrew the separated instrument. If the coronal diameter is larger or the canal curvature is greater than 15 degrees, use a larger needy rotary instrument to enlarge the canal followed by ultrasonic instruments to expose the coronal portion of the separated instrument. Mineral oil application. Apply mineral-based oil to the canal, facilitate separation of the instrument from the canal wall. Ultrasonic technique. Use ultrasonic tips to create a space around the separated instrument. Create a 90-degree semicircular space using a spoon tip, then expand it to 180 degrees with a straight tip. Ensure the ultrasonic tip is thin and placed on the inner canal curve to prevent secondary fracture. Apply pulsing and pecking motions during ultrasonic activation to prevent instrument fracture and temperature rise. Space depth. The depth of the semicircular space created on the inner curve should be longer than 1/3 of the fragment length and evenly distributed along the canal walls. Conformation. Ensure the separated instrument is seen dancing before making retrieval attempts. Dancing refers to movement from one place to another, indicating loosening, rather than flexing back to the original place. Root canal preparation for non-visible instrument retrieval involves specific techniques. Continuous presence of mineral oil. Mineral oil should be present throughout the procedure to help loosen the file fragment while preparing the root canal with ultrasonics. Use of thin ultrasonic tip. Use a thin and sharp ultrasonic tip to feel the time between the inner canal wall and the separated instrument. Grope for sticky feeling. Place a pre-curved spoon-shaped or sword-shaped tip in the space and grope for a sticky feeling while obtaining tactile sensation. Creation of 90-degree semicircular space. Activate the ultrasonic tip directly on the file fragment from the inner curve to create a 90-degree circular space. Low-intensity ultrasonic activation. Activate the ultrasonic tip with low intensity to prevent secondary fracture and breakage of the tip. Elimination of dentin walls. As root canal preparation continues, any dentin walls contacting the separated file will be eliminated by indirect ultrasonic ablation transferred from the vibrating tip, eventually loosening the fragment. Conformation and completion. When the sticky feeling is lost from the ultrasonic tip or the separated file emerges from the non-visible curve with ultrasonics, root canal preparation can be considered complete, and retrieval attempts can be made. Loose fragment beyond radicular foramen. If the separated file is loose beyond the radicular foramen and not engaged in the canal wall, it can be irrigated out of the canal using saline with ultrasonic irrigation devices. This conservative preparation technique minimizes invasiveness, but requires patience and may be unpredictable in terms of when the separated instrument will be ready for retrieval. However, it reduces the risk of secondary fracture or breakage. A. Separated file around the curve after the canal enlargement with a needy rotary file. B. Space needs to be created on the inside curve with the spoon ultrasonic tip, followed by the straight tip. C. Thin space created on the inner curve. D. Ultrasonic forces applied to the separated instrument from the outside curvature will reorient it in a radicular direction. E. Ultrasonic forces applied to the separated instrument from the inside curvature will reorient it in a coronal direction rather than a radicular direction. Instrument retrieval techniques involving ultrasonic oscillation. Conformation of canal wall smoothness. Ensure that the canal wall is smooth from the separated file to the coronal extent, with no overhangs on the outside canal wall. Assessment of file length and canal curvature. If the separated instrument is shorter than 3 mm or between 3.1 and 4.4 mm with a curvature smaller than 30 degrees, it can likely be retrieved with ultrasonics alone. Rinsing and filling the canal. Rinse the canal with silicone-based oil or EDTA solution and fill it up to the cavosurface to take advantage of cavitation and acoustic streaming for retrieval in wet conditions. Continuous activation of ultrasonic tip. Continuously activate the ultrasonic tip at a power setting slightly higher than during the preparation stage with short up and down strokes within the space created on the inner curve until the separated instrument is removed. Possible causes of failure. If the separated instrument doesn't come out in 10 seconds, potential reasons include inadequate space, the instrument being pushed back into place, or insufficient fluid in the canal for acoustic streaming and cavitation. Transition to mechanical retrieval. If ultrasonics alone are unsuccessful, or if the separated instrument is longer than 4.5 mm or between 3 and 4.4 mm with a curvature greater than 30 degrees, transition to using a loop, Yoshi loop, for retrieval. Use of loop for resistant instruments. Longer separated instruments, especially around severe curves, may require the loop for retrieval due to increased friction against the canal walls, making them more resistant to ultrasonic retrieval alone. Procedure for using the loop for instrument retrieval. Space requirement. Ensure there is at least a 0.4 mm diameter space in the canal to accommodate the loop, and the coronal portion of the separated instrument must be exposed by at least 0.7 mm for grasping. Adjust loop size. Use an endodontic explorer, such as a DG16 Endo Explorer, to adjust the loop size to fit the coronal diameter of the separated file. The loop is contracted or expanded around the explorer tip as needed. Pre-bend the loop. Pre-bend the loop to 45 degrees instead of 90 degrees to facilitate placement over the separated instrument and minimize invasiveness. Placement of the loop. Insert the loop into the canal and position it over the exposed portion of the separated instrument. Adjust the loop to 90 degrees upon contact with the instrument. Tightening the loop. Slide down the handle to tighten the loop securely over the separated instrument. Retrieval maneuvers. Retrieve the separated instrument by pulling the loop out of the canal in various directions with a swaying motion to dislodge it from the canal walls. Completion. A few pull motions in different directions usually dislodge the file fragment, completing the instrument removal procedure. A. Coronal portion of the separated file should be exposed at least 0.7 mm above the bottom of the space created around it. B. Approaching the separated file, with the loop bent at 45 degrees against it. C. Loop is pushed back at 90 degrees as it is placed over the separated file. Removal with the loop requires the diameters of the loop device, 0.16 mm, 0.45 mm, and the separated instrument and a depth of at least 0.7 mm. D. Separated file is pulled out with the loop device in various directions. The prognosis of a case where an endodontic instrument separates in a canal depends on several factors. Stage of instrumentation. The prognosis may be better if the file fracture occurs later in the canal instrumentation process, especially if it is at the apex, as the canal is likely well debrided and potentially free from microorganisms. Presence of infection. If the preoperative canal is not infected and there is no associated radicular periodontitis, the presence of the separated instrument may not affect the prognosis. Ability to remove the instrument. If the separated instrument can be predictably removed without sacrificing a significant amount of dentin, the prognosis will be reduced. In summary, the prognosis is influenced more by the removal of microbial infection than by the removal of the instrument itself. Ledge formation within root canals during endodontic procedures can lead to complications and hinder successful treatment outcomes. Here are the 14 possible causes identified. Insufficient access cavity extension. If the access cavity is not extended adequately, it can limit visibility and hinder proper instrumentation of the radicular portion of the root canal. Loss of instrument control. When attempting endodontic treatment through a cavity or restoration on a proximal surface, it can lead to a loss of control over the instruments, increasing the risk of ledging. Incorrect root canal direction assessment. Misjudging the direction of the root canal can result in deviation and ledge formation. Incorrect root canal length determination. Failure to accurately determine the length of the root canal can result in overinstrumentation and ledging. Forcing instrumentation into canal wall. Excessive force during instrumentation can cause the instrument to deviate and create ledges. Non-curved instruments in curved canals. Non-curvature compatible instruments in curved canals can lead to instrument deviation and ledge formation. Failure to use instruments sequentially. Not using instruments in the proper sequence can result in incomplete cleaning and shaping of the root canal, increasing the risk of ledges. Excessive file rotation at working length. Over-rotating files at the working length can cause instrument deviation and create ledges. Inadequate irrigation or lubrication. Lack of proper irrigation or lubrication during instrumentation can lead to debris accumulation and ledging. Over-reliance on chelating agents. Excessive use of chelating agents without proper instrumentation can weaken dentin structure, increasing the risk of ledging. Attempting instrument retrieval. Trying to retrieve separated instruments can further damage the canal walls and create ledges. Removing root-filling materials during retreatment. During retreatment procedures, improper removal of existing root-filling materials can result in instrument deviation and ledging. Attempting to negotiate calcified canals. trying to navigate through calcified canals without proper preparation can lead to instrument deviation and ledging. Packing debris in radicular portion. Accidentally packing debris into the radicular of the canal during instrumentation can obstruct the canal space and lead to ledging. Awareness of these potential causes can help endodontists take preventive measures and adopt appropriate techniques to minimize the risk of ledging during root canal procedures. Early recognition of ledge formation. Utilization of radiographs and magnification. Radiographs, including cone beam computed tomography, CBCT, and magnification aid in identifying the location of the ledge. Signs of ledge formation. Straightening of the canal, where the file is negotiating the curve. Looser feeling of the file within the canal without tactile sensation of binding. Radiographic evaluation. The tip of the instrument should appear at the midpoint of the root on radiographs. Deviation of the instrument tip away from the canal curvature indicates ledge formation. CBCT. CBCT can determine the number of canals in the root before instrumentation begins, especially if there are more than 2 canals in a single root. Importance of early detection. Early recognition allows for appropriate management to prevent further complications and preserve treatment outcomes. Guidelines for managing ledge formation. Selection of shortest file possible. Choose the shortest file that can reach the working length to bypass the ledge. Shorter instruments offer more stiffness, enhancing tactile sensation and control. Attributes required. Determination, persistence, and patience are essential for successful management. Visualization and sensation. Visualization of the ledge and original pathway is crucial. Cases where the ledge is visible under the dental operating microscope, DOM, are considered less complex. When the ledge is not directly visible, experienced infants are required to rely on tactile sensation and negotiation. Utilization of 3D radiographic images. Obtain 3D radiographic images from cone beam, computed tomography, CBCT, to locate the ledge and original pathway. CBCT reveals the locations and directions of structures, aiding in accurate diagnosis and management. Axial views help identify the maximum curvature of the root, while sagittal or coronal views show the relationship between the ledge and original pathway. CBCT provides additional information compared to 2D radiography, leading to more predictable outcomes in managing ledge formation and negotiating the original canal. Technique for ledge bypassing with hand instruments. Identification of original pathway. Identify the original pathway and open it under the dental operating microscope, DOM, using microhand instruments. Visualization of the ledge under the DOM is facilitated as it is created in a straight line direction. Caries detector dye or methylene blue dye can stain the orifice of the original pathway for better identification. Selection of microhand instruments. Use microhand files like the microopener with #10/.06 taper for flaring the orifice of the original pathway coronal to the ledge. Long instruments may be required to reach the ledge in the radicular third of a long canal, facilitated by hand instrument holders like the endo handle. Instruments like the TFRK Micro Explorer instrument, TFRK-ME, or gutta-percha removal instrument, TFRK-GPR, are specifically designed for this purpose. Widening and of ledge. Use the pre-curved TFRK-ME, along with the ELES and TFRK-GPR, in push-pull motions to widen the orifice of the original pathway and reduce or remove the ledge. Further shaping and reduction. Once the ledge is bypassed, hand instruments like ProTaper S1 and S can be used to shape and further reduce the ledge. ProTaper Gold files can also be utilized after preliminary enlargement of the original pathway with microhand instruments. Schematic diagrams showing bypassing the ledge with ledge removal hand instruments. A ledge is created in a radicular straight direction around a curve. B. Original pathway is explored and opened up with the Micro Explorer instrument in short push-pull strokes. C. Original pathway is widened with the ELES instrument. D. ELS instrument used in push-pull motions to reduce the ledge. E. Pre-curved straight ultrasonic tip can also be used here to reduce the ledge instead of the ELES instrument. File with a biconical tip is brought into the canal to eliminate/reduce the ledge and negotiate the original canal. The primary cone of the biconical tip has no cutting tip. As it hits the curve or irregularities on the canal wall, it will slip alongside the curve and scoot over the irregularities. Secondary cone of the biconical tip removes the points at the transition angles and provides a smooth surface that guides the tip portion into the original pathway. Orifice of the original canal beyond the ledge needs to be enlarged for easy file insertion after the ledge has been bypassed successfully. Orifice of the original canal can be efficiently widened with a pre-curved instrument such as a ProTaper S1 hand file and a #15/.04 vortex blue rotary file used as a hand file, and the apical patency established. Original canal can be sequentially prepared with more tapered needy files. Postoperative canal showing the ledge is significantly eliminated. Technique for ledge bypassing with hand files. Preparation of hand file. Pre-curve a number 8 or number 10 hand file to have a distinct curve at the tip. Initial exploration. Use the pre-curved hand file to negotiate and explore the original pathway of the canal to the radicular foramen. Guidance with rubber stopper. Set a rubber stopper with a directional indicator pointed in the direction of the original pathway to guide the instrument. Advancement technique. Employ a slight rotation combined with a pecking motion to advance the hand file to the full working length of the canal. If the initial technique fails, flare the canal coronal to the ledge in an anti-curvature direction to obtain wider straight-line access to the original pathway of the canal. Use of smaller pre-curved K-file. Subsequently, use a smaller K-file with the tip pre-curved to bypass the ledge. Ledge removal instrument, micro-explorer, to explore a canal for impediments and to penetrate a narrow canal beyond a ledge. Ledge is formed with perforation in a radicular straight direction. Microscopic view showing the ledged canal in the center and a narrow access to the pathway on the right side. The canal orifice as well as the access to the original pathway needs to be flared in an anti-curvature direction, red portions. Microscopic view showing red portions to be removed for easy access to the original pathway. Access to the original pathway was flared to facilitate file insertion. Bypassing file used in short push-pull strokes to create a distinct pathway to the original canal as the final glide path. Non-visible ledge removal with ultrasonics. Benefits of small diameter ultrasonic tips. Small diameter ultrasonic tips enhance visibility during endodontic procedures. They reduce the need for sacrificing sound dentin when bypassing or removing ledges in root canals. These tips are effective in tooth structure while addressing canal irregularities. Considerations for thinner ultrasonic tips. Thinner tips are more prone to fracture during ultrasonic activation. Activation should be done in a pulsing fashion at the lowest power setting to prevent fracture and minimize heat generation. Utilizing longer ultrasonic tips. Longer ultrasonic tips can facilitate bypassing or reducing ledges in the radicular third of the canal. When used under a dental operating microscope, DOM, they offer enhanced precision. Enlarging the orifice of the original canal just coronal to the ledge is crucial for successful treatment. Procedure for using ultrasonic tips. Select an appropriate size of small diameter ultrasonic tip and pre-curve it in the direction of the original canal. Place the pre-curved tip in the orifice of the original pathway to the radicular foramen. Activate the ultrasonic tip to automatically enlarge the opening of the true canal. Ultrasonic instruments cut dentin faster and widen the orifice more easily compared to hand instruments. Use ultrasonics at the lowest power setting to prevent overextending the ledge. Once the orifice is wide enough, place negotiation files into the canal to establish patency and smooth out irregularities. Follow up with root canal preparation using needy rotary or hand files for thorough cleaning and shaping. Key points to remember. Ultrasonic tips offer precision and efficiency in managing canal irregularities. Careful selection and activation of ultrasonic tips are essential to prevent instrument fracture and preserve tooth structure. Utilizing ultrasonics under magnification, such as a dental operating microscope, enhances procedural outcomes. Non-visible ledge removal with ultrasonics. A. Ledge formed beyond the curve. CBCT is taken to locate both the ledge and the original pathway. B. Canal coronal to the ledge is flared in an anti-curvature direction. With needy rotary files in brushing motions. Original pathway to the canal terminus is explored with a number 10 pre-curved K-file or the pre-curved microexplorer instrument, and radiographs are taken with it inserted in the canal to see if it is in the original canal beyond the ledge. C. Straight ultrasonic tip is pre-curved the same as the hand instrument used and placed in the canal to eliminate/reduce the ledge. The red portion needs to be smoothed out to facilitate the insertion of an instrument into the original pathway. D. Postoperative canal showing the ledge is significantly reduced. Steps for ledge bypassing with rotary instruments. Canal enlargement and visualization. Enlarge the canal coronal to the ledge for better visualization of the original pathway. Locate and open the orifice of the original pathway. Selection of instruments. Use pre-curved smaller diameter files with smaller tapers, e.g., path files and race 10, for negotiating beyond the ledge. Preparation of the instrument. Pre-curve the radicular 2 to 3 mm of the file to the original pathway based on CBCT view. Technique. Rotate the instrument at a low speed or with receding motions as it is slowly brought into the canal and moved radicularly. If a ledge or sharp radicular curvature is encountered, withdraw the instrument about 1 mm and immediately reinsert it. This allows the pre-curved tip to move to a different orientation within the canal. Repeat this procedure as needed, which may require 1 or 2 withdrawals and reinsertions to negotiate the original canal. Progressive enlargement. Use larger rotary files in sequence to preliminarily enlarge the original pathway and reduce the ledge. Proceed with conventional root canal preparation using needy rotary instruments once the ledge is sufficiently reduced. Complications during ledge management. Root fracture. Risk increases due to the compromised structural integrity of the tooth. Perforation. Attempting to bypass or remove ledges may lead to perforation, especially around curves. Exacerbation of ledge. Aggressive attempts to manage ledges can worsen the situation. Instrument separation. Overstressing instruments during ledge management may result in instrument separation. Challenges in ledge management. Ledges often form around curves, necessitating sacrifices of dentin during removal or bypassing. Dentin removal can compromise tooth integrity and increase the risk of perforation or fracture. Advanced treatment options. Failed ledge bypassing. If periradicular lesion symptoms persist, advanced treatments may be necessary. Options. Gentle wave system. Utilizes advanced fluid dynamics, acoustics, and chemistry to clean and disinfect the entire root canal system. Effective even in complex anatomies beyond ledges, offering success in infection elimination without traditional shaping where access is limited. Surgical intervention. Periradicular or intentional replantation may be considered if ledge management fails to resolve symptoms. Importance of glide path preparation. Prevention of mishaps. Crucial for preventing ledge formation and canal transportation. Ensures root canal diameter is adequate for shaping instruments. Techniques to prevent ledge formation. Pre-curving instruments. Avoiding force insertion. Preferred instrumentation. Needy reciprocating instrumentation preferred. Reduces procedural errors, even among novice clinicians, compared to traditional methods. Role of non-cutting tips. Instruments with non-cutting tips help maintain original canal curvatures. They slip along the walls without cutting into them. Flexibility and canal centering. Flexibility, especially in needy instruments, aids in keeping them centered in the canal. Advanced needy alloy instruments. Instruments with controlled memory or gold alloy technologies further enhance canal centering and reduce transportation. Prognosis of canal with a ledge. Dependent factors. Prognosis hinges on the ability to bypass or remove the ledge without compromising tooth integrity or causing complications. Effective management. If the ledge can be effectively managed and the canal beyond it cleaned without excessive enlargement or perforation, prognosis shouldn't be significantly compromised. Factors influencing prognosis. Efficacy of disinfection process. Host response to any remaining debris or biofilms in the canal. Conventional root canal therapy may not fully remove all debris or biofilms. Considerations. Success relies on ensuring complete removal of debris and effective disinfection to prevent further complications. Thorough assessment and meticulous treatment planning essential for optimal outcomes. Complications of radicular extrusion. Inflammatory reactions. Post-treatment inflammation, flare-ups, hindered radicular healing. Gutta-percha extrusion can lead to severe inflammatory reactions. Biocompatibility of materials. Gutta-percha may cause severe inflammation while materials like MTA and endosequence BC sealer are more biocompatible. Factors contributing to extrusion. Instrumentation techniques, types of instruments used, and root canal filling materials. Uncontrolled obturation techniques may lead to extrusion into sensitive areas like the maxillary sinus or tear of the inferior alveolar nerve, IAN. Complications. Maxillary sinusitis, paresthesia, dysesthesia, neural injuries. Material-specific consequences. Resin-based sealers generally lead to full recovery from nerve injuries. Paraformaldehyde-based sealers result in permanent nerve damage. pH of endodontic materials crucial, with higher or lower pH potentially causing cellular necrosis or neuropathic pain. Prevention. Careful instrumentation and obturation techniques. Awareness of endodontic material properties. Caution extrusion and minimize associated complications. Nerve injuries from overextruded endodontic materials. Common locations. Most commonly reported in the first or second mandibular molars, followed by the second mandibular premolars. No reported cases in maxillary teeth. Implications of extrusion. Extrusion of obturated materials, although relatively low, around 3%, can contribute to endodontic failure. Material beyond radicular foramen may harbor biofilms or fail to fill small anatomical spaces, impacting treatment success. Factors contributing to extrusion. Instrumentation techniques, canal shaping, obturation methods, and open apices with large or minor foramens. Accidental overinstrumentation, incorrect canal length measurement, and warm vertical compaction techniques increase risk. Carrier-based obturation methods tend to result in more extrusion compared to warm vertical compaction. Impact of canal shaping. Continuously tapered canal shapes less prone to extrusion compared to parallel coronal preparation and tapered radicular preparation. Endodontic retreatment considerations. Techniques involving push-pull filing strokes may lead to greater debris mass and increased risk of extrusion. Consideration of instrumentation and obturation techniques essential to minimize risk and improve treatment outcomes. Non-surgical management of extruded obturation materials. Manual and mechanized methods. Mechanized methods, though faster, may not significantly differ from manual methods in terms of remaining material in the root canal. Mechanized removal methods. Heat-carrying instruments, ultrasonic solvents, and rotary or reciprocating files. Caution needed with heat-carrying instruments to avoid damaging pararadicular tissues. Solvents like chloroform aid in gutta-percha removal, especially when combined with microhand instruments or headstrom files. Manual methods. Utilize instruments like H files, microdebriders, e.g. PRL/R/U/D, and TFRK gutta-percha removal instrument. Single file systems, e.g., SAF, HighFlex EDM, Wave 1 Gold, Reciproc Blue, XP Shaper, improve mechanical properties for gutta-percha removal. XP Shaper particularly efficient without adverse events, especially at higher speeds. Combination approach. Employ rotary and hand instruments for better cleaning, especially in radicular third of the root. Solvents and bacterial reduction. Solvents like chloroform enhance gutta-percha removal and reduce intracanal levels of bacteria like Enterococcus faecalis. Caution required due to potential carcinogenicity of chloroform. Diagrams showing removal of gutta-percha filling materials extruded beyond the radicular foramen. A. Solid gutta-percha filling extruded beyond the radicular foramen. B. Small space is created between the canal wall and the gutta-percha filling with a thin ultrasonic tip, such as a FRKS ultrasonic tip. C. Gutta-percha removal. Hand instrument, such as the GPR instrument and the eGPR instrument, is brought into the canal with the tiny projection pressed against the gutta-percha filling to pull it out. D. Extruded gutta-percha root filling portion separated from the coronal portion within the canal. E. Chloroform is filled in the canal using a gutta-percha removal hand instrument and agitating it to dissolve the extruded portion. F. Gutta-percha filling material is diluted and dissolved with the hand instrument in push and pull motions. Root filling materials extruded beyond the radicular foramen. A. Preoperative radiograph showing overextension of the root filling material with a large lesion associated with the root. B. Root filling in the canal was mechanically removed, but the extruded portion of it remained in the pararadicular tissue. C. MTA was filled in the canal with the extruded portion remaining in the lesion. D. 6-month postoperative radiograph showing the reduced size of the lesion, but the lesion surrounding the extruded portion stayed the same in size for the next 6 months, indicating infection of the extruded gutta-percha point. The extruded portion was surgically removed from the lesion at this point. E. 3-month follow-up radiograph after the surgery showing the healing lesion. F. 12-month follow-up radiograph after the surgery showing a more pararadicular. G. Gutta-percha point retrieved from the lesion. Removal of extruded root fillings. eGPRL/R/U/D hand instruments and GPR instrument. Designed to remove obturation materials from both the radicular third of the canal and pararadicular tissues through the radicular foramen. eGPR instruments have tiny projections on the tip for scraping and engaging gutta-percha filling. TFRK GPR instrument has a conical harpoon-shaped tip for hooking gutta-percha on the return stroke. Utilization of endo-handle. Endo-handle with a pre-bent 30 mm hand file attached to the locking chamber can remove root fillings extruded into radicular tissues. Create a hole with a small diameter ultrasonic tip between the canal wall and gutta-percha filling. Place the hand gutta-percha removal instrument into the hole to facilitate removal of the root filling. Scrape and remove the gutta-percha filling from the canal wall with the microinstrument. Use of chloroform. Chloroform dissolves residual root filling material, aiding in its removal. Most studies report less than 10% residual material after chloroform use. Management of tissue damage. Non-surgical methods. Analgesics, cold packs, corticosteroids, and antibiotics are commonly employed. Methazone, a corticosteroid, effectively decreases pararadicular inflammation with minimal side effects. Special cases. If tissue damage extends to the inferior alveolar nerve, IAN, or maxillary sinus, a different approach may be necessary for management. Maxillary sinus perforations. Proximity to sinus. Maxillary premolars and molars are often close to the sinus, with apices less than 2 mm from the sinus floor. Tolerance to sinus exposure. Exposure of the sinus lumen is generally well tolerated. Applications. Introduction of foreign materials during procedures can lead to thickening of the sinus mucosa and symptoms of maxillary sinusitis. Diagnostic challenges. Conventional radiographs have limited value in predicting oroantral communication, OAC. Cone beam computed tomography, CT, provides more informative measurements. Complications from extrusion. Root canal filling material extrusion into the maxillary sinus may lead to complications. Surgical intervention may be necessary for adequate management to prevent conditions such as aspergillosis. CBCT image in coronal view showing that the mesiobuccal root apex of a maxillary second molar is in close proximity with the sinus floor. Maxillary sinus aspergillosis. A. Preoperative radiograph showing a lesion associated with the palatal root, from which the extrusion of the root-filling materials occurred in the maxillary sinus. B. CBCT image in sagittal view showing the relation between mucositis, maxillary sinus floor, and the gutta-percha filling material. C. CBCT image in axial view showing the relation between mucositis on the mesial wall of the maxillary sinus and the extruded root-filling materials. D. CBCT image in coronal view showing the relation between the palatal root and the extruded root-filling materials. E. Postoperative radiograph of orthograde root canal retreatment on the maxillary left first molar showing the mesiobuccal, distobuccal, and palatal root canals were adequately filled without overextension of the filling materials. F. Aspergillosis found on the filling materials retrieved from the maxillary sinus. Injuries to the inferior alveolar nerve, IAN. Presentation of sensory neuropathy. Symptoms manifest within the affected dermatome. Common symptoms include allodynia, pain in response to touch or cold stimuli. Hyperpathia, prolonged pain after the stimulus is removed. Hyperalgesia, increased sensitivity to painful stimuli. Other symptoms may include ongoing spontaneous altered sensation. Diagnostic considerations. Evaluation of neuropathic areas and sensory abnormalities within the dermatome. Clinical assessment for sensory dysfunction. Management. Treatment strategies may involve pain management techniques, physical therapy for sensory reeducation, surgical interventions in severe cases, psychological support for coping with neuropathic pain, inferior alveolar nerve injury, sensory nerve sensitivity, susceptible to physical, radiation, chemical, thermal, and ischemic damage. Capacity to heal, but severe damage may lead to persistent post-traumatic sensory neuropathy. Presenting symptoms. Neuropathic within the dermatome of surgery/injury. Allodynia, pain to touch or cold. Hyperpathia, continued pain or altered sensation after stimulus removal. Hyperalgesia, increased pain to painful stimuli, e.g., exaggerated response to sharp/blunt discrimination tests, bite numbness. Additional symptoms, ongoing spontaneous or elicited altered sensation, paresthesia or dysesthesia, tingling/formication, burning/shooting pain, or electric shock. Sensory deficits. Mechanical function deficit indicates damage to larger myelinated fibers. Noxious and thermal stimuli deficit indicates damage to small diameter afferent fibers of the spinothalamic tract. 4. Medical language. Avoid referring to sensory neuropathy as paresthesia, which is a clinical sign, not a diagnosis. Neurologists categorize as hypoesthetic, predominantly numb with reduced mechanosensory function, or hyperesthetic, ongoing pain or dysesthesia. 5. Post-traumatic neuropathic pain, PTNP. Recognized neurologic diagnosis. 6. Impact on patients. Functionally and psychologically severe, especially when painful and iatrogenic. Trigeminal nerve protects eyes, nose, mouth, and brain, thus, pain's effective emotional reaction is immense. Interference with daily activities, speaking, eating, kissing, shaving, applying makeup, toothbrushing, and drinking. 7. Management. Complex, curative treatment unavailable, prevention crucial. Trigeminal nerve injury, challenging consequence of dentical procedures with significant medical-legal repercussions. Incidence of IAN injury estimated at 5%, with about one-third experiencing neuropathies, including neuropathic pain. Common causes of damage to the inferior alveolar nerve. Local anesthetic injections. Mechanisms, physical, needle damage, hemorrhage, or chemical, local anesthetic contents. Implicated agents, high concentrations of certain local anesthetics, e.g., prilocaine 4%, articaine 4%. Third molar surgery. Highest reported incidence of nerve damage. Implants. Potential for nerve injury during placement. Endodontics. Extrusion of materials used in treatment. Over-instrumentation. Elevated temperatures. 5. Ablative surgery. Surgical procedures involving tissue removal. 6. Trauma. Physical injury to the nerve. 7. Orthognathic surgery. Surgery to correct jaw discrepancies. Incidence. Local anesthesia, second common cause. Endodontic procedures, relatively small percentage, 8%. Root canal treatment of mandibular, premolars, incidence up to 1%. Risk factors. Mechanisms of injury, scalpel blade wounding, crushing, stretching. Chemical factors, age of dental materials, ischemia, hemorrhage, thermal factors. Management, surgical exploration and irrigation of damaged nerves. Complications. Persistent neuropathy, resulting from various factors including mechanical, chemical, ischemic, and thermal damage. Symptom: neuropathic pain, altered sensation. Prevention. Careful surgical techniques. Monitoring temperature changes during procedures. Consideration of sealer cement type used in endodontic procedures. Factors responsible for inferior alveolar nerve, IAN, damage during endodontic treatment. Chemical toxicity and mechanical pressure. Mechanisms: leakage of sealers into areas close to the mandibular canal. Potential injury to IAN and mental nerve. Cytotoxicals, used in preparation, e.g., irrigation liquids, intracanal medicaments, and obturation, materials containing paraformaldehyde. High pH levels, immediate nerve damage, likely to be permanent. Mechanical factors. Repeated insertions of endodontic instruments through the apex into the eye and surrounding tissues. Thermal factors. Mechanism: inappropriate or prolonged heat application. Diagnosis of post-traumatic sensory neuropathy. Relies on clinical signs and symptoms. Preoperative risk assessment and post-treatment radiographs for confirmation. Radiographic assessments. Additional assessments like CBCT may offer insight into extruded materials' extent and location. May not significantly alter treatment outcomes. Chemical nerve injuries may not be visible on radiographs, especially without radiopaque material present in the canal postoperatively. Transient paresthesia. May occur due to prolonged surgical procedures, inadvertent stretching, or excessive postop edema. Reevaluation appointments include neurosensory testing and mapping of sensory deficits. Return of sensation within the first few weeks indicates neuropraxia. Differentiating between temporary and permanent nerve injuries early is challenging. Treatment approach. Based on symptom severity, neuropathy extent, and evidence of injury. Timely intervention is crucial. Follow-up protocol. High-risk patients should ideally be followed up for 24 to 60 hours post-endodontic treatment. Monitoring for neuropathic symptom onset during this period is essential. Incidence of inferior alveolar and lingual nerve damage. Third, molar extractions. Highest reported incidence of nerve damage. Local anesthesia. Second most common cause of nerve injury. Mechanisms. Physical, needle damage, epidural/perineural hemorrhage. Chemical, contents of local anesthetics. Implicated local anesthetics. High concentrations of prilocaine 4% and articaine 4%. Endodontic procedures. Relatively small percentage, 8%, of IAN injury cases associated with endodontic procedures. Important points regarding inferior alveolar nerve, IAN, damage. Compression effects. Compression of peripheral sensory nerves over 6 hours can lead to nerve fiber atrophy. Ischemia alone, without direct nerve damage, can cause sufficient neural inflammation and permanent nerve injury within 6 hours. Temperature increase. Damage to the IAN may occur when the temperature increase proximal to the nerve is greater than 10 degrees Celsius. Sealer cement influence. The type of sealer cement used in endodontic procedures may influence the symptoms of IAN damage. Risk assessment for prevention of endodontic nerve injury. Preoperative assessment. Preoperative assessment is crucial for preventing nerve injury related to endodontic procedures. Radiographic assessment using periapical images is mandatory, and in critical cases, CBCT may provide more precise information proximity to nerve structures. Distance consideration. Careful consideration should be given to the distance between the root apices and the mandibular canal. For mandibular first molars, this distance varies between 1 and 4 mm, while for mandibular second and third molars, it can be less than 1 mm. Proximity of a mental foramen should always be considered, especially in mandibular premolars. Maxillary second molars. CBCT studies have shown that the mesiobuccal root apex of maxillary second molars is frequently in very close proximity to the sinus floor, predisposing radiological factors that may indicate a higher risk of an adverse incident during root canal treatment or cause an extrusion of endodontic filler and hypochlorite accident. Resorption defects. Internal or external resorption defects, especially when the extent is not clearly identified and there is communication with canal and external surface of the root. Perforation suspicions. Suspicion of a perforation that communicates with the external surface of the root. Root fracture. Presence of a root fracture where there could be potential communication of the root canal with the external root surface. Sclerosed root canal. Sclerosed root canal, which may pose challenges during root canal treatment and increase the risk of complications. Dens invaginatus. Presence of dens invaginatus, a developmental anomaly that may complicate root canal treatment due to complex canal morphology. Bone lesions. Presence and diameter of bone lesions of endodontic origin, which may influence the occurrence of paresthesia, particularly when associated with premolars and lower molars. Prevention of nerve injury related to endodontics. Assess proximity to IAN. Always assess the proximity of the tooth apex to the inferior alveolar nerve, IAN, before performing endodontic treatment. Identify risk factors. Evaluate additional risk factors related to root morphology and bone structure that may contribute to leakage of chemicals adjacent to the IAN. Minimize apical breach. Take all necessary steps to minimize apical breach during endodontic treatment, especially if any of the identified risk factors are present. This helps prevent leakage of high pH chemicals into the IAN, which can cause chemical damage. Immediate action for neuropathy. If a patient develops sensory neuropathy within 3 days of endodontic treatment, consider immediate extraction of the tooth. Generous lavage of the socket and adjunctive medical treatment should also be administered. Operative techniques to minimize nerve injuries. Presurgical assessment. Use radiographs and CBCT to assess the size, location, and spatial relation of the planned surgery to nearby trigeminal nerves, including the IAN, mental nerve, and mental foramen. Careful tissue reflection. Control the reflection of tissue overlying the suspected location of the mental foramen to diminish the incidence of transection. Cautiously reflect the flap to reveal evidence of tissue funneling at its base, which indicates the exiting nerve bundle. Marking exiting tissue. Mark the exiting nerve bundle with a dot of gentian violet ethylene blue dye to avoid unintentional impingement with a retractor during surgery. Minimize tissue distension. Keep tissues minimally distended during surgery to reduce the risk of nerve injury. Maintain the underside of the flap well hydrated throughout the procedure. Prevention of overinstrumentation. Confine instrumentation and irrigation processes within the canal space to prevent chemical or mechanical damage from extrusions. Close monitoring for 72 hours postoperatively is crucial in cases where extrusion is apparent to detect any potential onset of paresthetic symptoms. Prevention of overfilling with beyond apex extrusion. Teeth close to the IAN canal require special attention during endodontic therapy, especially when using NaOCl for irrigation or calcium hydroxide as a sealant, as they can breach the canal roof and cause vascular bleeding resulting in nerve irritation. Prevention of thermal injury. Avoid imprudent heat application during thermoplastic compaction of gutta percha to prevent IAN injury. Recognition and recording of operative nerve injury. Be vigilant for signs of operative nerve injury, such as extreme pain during various procedures and sudden profuse hemorrhage from the apex of the. Record any such events promptly. Postoperative assessment. Take appropriate postoperative periapical radiographs to check for any extrusion of dressing or filling materials into the inferior dental canal or around the mental foramen according to endodontic clinical guidance. Conduct home checks, especially for high cases, to assess for persistent or new neuropathy symptoms. Patient education and support. Prioritize understanding of the situation, prognosis, and available interventions. Discuss medical and surgical options. Holistic management. Address neuropathy, associated pain, functional issues, and psychological impact. Study findings. Grodz et al. Reported on 11 patients with endodontic-associated neuropathy. Dominance of hypoesthesia and dysesthesia noted, with 50% reporting pain. Treatment approaches include apicectomy, nerve decompression, and tooth extraction as necessary. Pain post-surgery was reported in only one patient. Differentiation of nerve injuries. Crucial to differentiate between endodontic and local anesthesia-caused nerve injuries. Careful questioning and clinical neurologic assessment aid in this discrimination. Neuropathic area mapping. Helpful in distinguishing between inferior dental block and endodontic nerve injury. Diagnosis of post-traumatic sensory neuropathy. Relies on clinical signs and symptoms. Preoperative risk assessment and post-treatment radiographs for confirmation. Radiographic assessments. Additional assessments like CBCT may offer insight into extruded material's extent and location. May not significantly alter treatment outcomes. Chemical nerve injuries may not be visible on radiographs, especially without radiopaque material present in the canal postoperatively. Transient paresthesia may occur due to prolonged surgical procedures, inadvertent stretching, or excessive postop edema. Reevaluation appointments include neurosensory testing and mapping of sensory deficits. Return of sensation within the first few weeks indicates neuropraxia. Differentiating between temporary and permanent nerve injuries early is challenging. Treatment approach. Based on symptom severity, neuropathy extent, and evidence of injury. Timely intervention is crucial. Follow-up protocol. High-risk patients should ideally be followed up for 24 to 60 hours post-endodontic treatment. Monitoring for neuropathic symptom onset during this period is essential. Assessment of suspected nerve injury. Key aspects. Evaluate pain intensity, functional limitations, and psychological impact. Confirm neuropathic area and perform mechanosensory testing for symptom assessment. Holistic assessment. Consider patient's event history in relation to pain initiation. Exclude pre-existing neuropathic pain. Factors to consider: severe pain during procedure, high-level post-surgical pain, ongoing pain, altered sensation, numbness, functional problems, and psychological issues. Understanding neuropathy, mechanism and duration. Neuropathy guide management decisions. Investigations. Radiological assessments. LCPA, lateral cephalometric projection analysis, and CBCT, cone beam computed tomography, post-trauma. Neurosensory testing. Confirm presence of neuropathy and relation with potential nerve injury. Diagnostic local anesthesia blocks. Evaluate peripheral pain management strategies if medical management fails. Advancements in imaging. Medical resonance neurography improves early postoperative assessment of trigeminal nerve injury, enables earlier surgical intervention if necessary. Immediate intervention. Nerve section or severe injury. If scalpel or drill-related nerve injury is suspected, immediate repair is necessary. Gap repair. If the transected nerve ends are closely approximated, axons will attempt to bridge the gap. Surgical intervention may be required if the gap is a critical length to prevent neuroma formation. Neuroma resection. Treatment within 3 months often involves resection of neuroma followed by tension-free anastomosis or nerve grafting. Early intervention. Neuropathic signs during instrumentation. If severe neuralgia occurs during or after instrumentation, post-treatment grafts should be re-evaluated. Delayed sensory neuropathy. Chemical leakage through the tooth apex may lead to delayed sensory neuropathy, not visible on radiographs. Permanent changes. Permanent central and peripheral changes occur within 3 months of nerve injury, making surgical intervention less effective. Prognosis. The duration and severity of injury correlate with the prognosis. Prolonged irritation increases the likelihood of permanent paresthesia. Management. Surgical removal. Symptomatic patients with significant extrusion or over-instrumentation into the IAN canal may require immediate surgical removal of offending materials. Timely intervention. Materials should be removed within 24 to 48 hours via periapical surgery, tooth extraction, or surgical debridement. Retention of treated tooth. For patients wishing to retain the tooth with overfill in the IDC, immediate mandibular buccal corticotomy may be advised. Persistent symptoms. If sensory improvement is not evident after 2 months, the prognosis for recovery is poor. Counseling and systemic medications for chronic pain should be considered. Counseling and medical management. Counseling and medical therapeutic management should be initiated within 48 hours for injuries caused by endodontic treatment or local anesthetic injections. Watch and wait approach. Minimal neuropathic area. If the neuropathic area is minimal and tolerable, intervention may not be necessary. Patient understanding of risks and benefits is crucial. Toxicity and pressure. Resorbable or inert materials causing IAN damage may dissolve over time, but cause permanent damage due to toxicity. Pressure from hematoma or inflammation can also contribute to nerve damage. Prognosis factors. Prognosis depends on the severity of direct nerve injury, toxicity of irritant, resorption rate, and promptness of causative agent removal. Mechanical and chemical nature. Removal of excess material may not suffice if nerve fibers have undergone degeneration from a chemical irritant. Healing timeline. Healing usually occurs within days for minor irritation, but may take 3 to 6 months for more severe cases. After this period, chances of healing decrease. Therapeutic approach. Therapy management may include medical and psychological interventions. Medical management. Steroids and NSAIDs. Steroids, prednisolone, and high-dose NSAIDs may minimize acute surgical neural inflammation and maximize recovery. Vitamin supplements, vitamin B complex, and magnesium supplements may aid in neural recovery. Antibiotics, not recommended unless infection-related neuropathy is suspected. Chronic pain management, tricyclic antidepressants, oxcarbazepine, topical lidocaine patches, and clonazepam may be effective for chronic neuropathic pain. Surgical intervention, direct repair or allograft cadaveric grafts have limited impact on trigeminal neuropathic pain. Overall management. Acknowledgement and support. Acknowledge and provide holistic support for patients with iatrogenic nerve injuries. Prevention. Prevention of nerve injuries is crucial, and early recognition and management are essential for favorable outcomes. Cervicofacial subcutaneous emphysema, CFSE. Definition: penetration of air or gases beneath the skin and submucosa, causing soft tissue distension. First recorded instance, Turnbull in 1900 documented a case where a musician induced CFSE by playing a bugle immediately after a molar tooth extraction. Causes: tooth extractions, especially mandibular third molars, remain the most common cause. Other procedures like restorative treatments, periodontal surgery, crown and bridge treatments, and root canal therapy can also lead to CFSE. Compressed air delivered through airsols or high-speed handpieces is associated with 71% of cases. Mechanisms of air introduction. Dental laser, air, YAG, use in gingival pockets. Hydrogen peroxide beyond the canal space. Lack of rubber dam isolation leading to air infiltration through the gingival sulcus. Barotrauma secondary to Borhave syndrome, spontaneous rupture of the distal esophagus. Clinical presentation. Soft, skin-colored swelling with crepitus, crunchy feeling upon palpation. Pneumomediastinum may present with dyspnea, brassy voice, chest or back pain, and Hammond sign. Complications. Soft tissue infections, airway compromise, optic nerve damage, pneumomediastinum, pyogenic mediastinitis, or necrotizing fasciitis. Differential diagnosis, allergic reaction, hematoma, angioneurotic edema. Management. Prompt evaluation and management of secondary complications. Differential diagnosis, to rule conditions. Evaluation may include blood cultures and broad-spectrum intravenous antibiotics. Close-up view reveals marked distension of the left suborbital region, with ptosis of the eye and loss of the nasolabial fold. There was marked crepitus upon palpation, but the patient was pain-free. She was placed on an antibiotic regime, as per the protocol. 2 days after the incident, the emphysema has resolved and the tissues are normal in color and texture. Treatment of cervicofacial subcutaneous emphysema. Empirical treatment. Treatment depends on the extent of CFSE. Antibiotics are usually prescribed due to potential non-sterility of the air supply and the risk of introducing microorganisms into surrounding tissues. Oxygen therapy. Administration of 100% oxygen via a non-rebreather mask can hasten resolution by replacing trapped air, which is more readily absorbed at the site. Hospitalization. More severe cases may require hospitalization with intravenous antibiotics. Close monitoring using CT scans and effective management of complications can be done in a hospital setting. Resolution. CFSE typically resolves rapidly and without complications. Patients usually return to their normal appearance within 4 to 7 days. Preventive measures, from an endodontic perspective. Minimize compressed air at the site, especially from high-speed handpieces or air syringes. Isolation with a rubber dam, using paper points or high-volume aspiration for drying canal spaces, and avoiding hydrogen peroxide during procedures can reduce the risk of introducing air. For endodontic microsurgery, using rear-exhausting high-speed hands and ultrasonics for root end preparation can decrease the likelihood of CFSE during procedures.